big thing to differentiate here, we're going to talk about more, and it's a principle you guys have to understand, is community acquired versus nosocomial, so cap and half. We'll talk about it more, but don't get those two mixed up. Everybody's fluent in Greek, right? So pneumonia, disease of the lungs. So now it's actually the actual lung tissue, the alveoli and the surrounding tissue. This isn't the airway. Pulmonary one was more focused on airway disorders. This is going to be more focused on actual lung tissue. Typically infectious, right? Bacterial, virus, fungi. You'll also hear the term pneumonitis, right? That's kind of just inflammation, which pneumonia, I guess, kind of falls underneath it. The big difference is pneumonia is some type of infectious agent. Pneumonitis is just inflammation, that's a trigger that's causing that. Prognosis, so if a patient's healthy, they usually have a good response if they get adequate, appropriate medical care. But if there's immunocompromised, they're elderly, or comorbidities, you're going to see a higher death rate, higher morbidity, and mortality. Another way, so if you want to be kind of smart when you're, especially in your phase 2, your clinical sites, when you're describing something, you want to be as specific as possible. So you're kind of painting a picture, right? If you think about like a telephone console or you're doing telemedicine, you want to be able to describe to that person what you're seeing if they don't have pictures or videos. So etiology, if I can identify that, bacterial, viral, fungal. The location, again, that's important because it's going to depend on our bugs that we're treating. Community acquired, usually less severe. Hospital acquired or nosocomial. Typically that's going to be a more severe, or bacteria or the infectious agent is going to be more resistant to certain medications. Areas affected, again, going back to that x-ray, you can say lobar versus interstitial, is it all over the place? Severity, we'll talk a little bit more about that. And then classifications. Was this aspiration, was this a witnessed event? Was it a patient in the nursing home that has swallowing difficulty? What's some other issues that can cause like swallowing issues? What's some issues that are some diseases that could cause like swallowing issues? Okay. Myasthenia gravis. What about ALS, Lewy disease? Some type of paralysis. Patients heavily sedated. There's supine. Those things will put them at increased risk. Is this chronic? Is it necrotizing? We'll talk a little bit more about necrotizing. It's more so secondary effects of pneumonia. But cap. All right, so this is kind of a bimodal right here, right? So we have a peak in that less than 2-year-old, goes down, 18 to 39. This is going to be the majority of what we treat on active duty. Then it increases up here. So what would be some explanations for this? Immune response, decrease. So babies are kind of like old people, right? They can't fend for themselves. They don't have great cough reflexes. They're kind of bed dependent, right? They're not able to clear their secretions necessarily on their own. So you think about that immune system. Babies, their immune system hasn't completely developed. They haven't gotten all their vaccines. Elderly, their bodies start to fail them. They have comorbidities. Just think about that when we think about our patients. Death rate. Pretty good death rate in the 90s for pediatric patients, right? Why do we think that's decreased so much? What kind of vaccines? Pneumococcal. What's interesting about pneumococcal? Is it bacterial or viral?
Bacterial.
So it's a bacterial vaccine, right? So now it's recommended for anybody over the age of 65 and anybody under the age of 5. And then in between, there's other recommendations as far as if they have comorbidities or some underlying disease that would indicate that. Also, we've gotten a lot better at diagnosing it and treating it. We're more aggressive with antibiotics. Pediatric patients are difficult because what? They can't tell you what's wrong with them. They cry, you kind of look at them. Like my daughter wakes in the middle of the night, you change your diaper, you feed her, she's still crying, you burp her, you're doing everything. You're like, dude, what is going on? Why are you being a little asshole? Like, what? I don't condone it. By any means, don't take this to Mr. Rakowski condones. But I understand shaken baby syndrome after having a baby. Like, I totally get it. Like, how I can lead to that point. I'm not condoning it. I'm not saying it's a good thing. I'm not saying I would ever do it. One of the best pieces of advice was a nurse who's like, the baby's crying, you can't console him, just put him down and walk away. Like, I can come back in a minute, like when you reset. But baby's crying, man. I was like, they're screaming at your ear. You're like, what is going on? Like, I can't help you. But just, this is a lot because of vaccines and early diagnosis and early intervention. So this is a key concept to understand to differentiate CAP and HAP, or hospital-acquired pneumonia. Community-acquired, right, outside of any medical facilities. They're just at home, they're at work. It occurs, onset occurs within the first 40 hours of a healthcare setting. So if you have a question, patient's been admitted for 24 hours and developed, is that a HAP or CAP? It's CAP, right? So kind of differentiate the things that can change that is, what if you work in healthcare? Because you're going to have patients, like healthcare providers, get sick, so that's important questions to ask when you're getting your history. Do you work around sick people? Do you work in a hospital? Are you a resident who spends 100 hours more time at work than you do at home? Second most common infectious cause of death in the U.S., directly or indirectly. Second most common cause of hospitalization. So on your phase 2, when you get your clinical sites, you do inpatient rounds in internal medicine, family medicine, pediatrics, you're going to see a lot of pneumonias. Viral atypical pneumonia, less association with age. The bacterial, again, it's that bimodal what we talked about. The pediatric patients and the elderly. We go look down here now, risk factors. You might want to know those, right? So those are very similar in pediatrics and elderly, right? Decreased cough reflex, babies can't clear, they choke on their milk. Elderly do that. I don't think I can have a conversation with my dad anymore without him like drinking something. If he's trying to talk and drink, it's just a nightmare. I'm just like, all right, drink now, Dad. Right? Decreased ciliary function. What's another patient that has decreased ciliary function besides elderly and pediatrics? Smokers, right? So we talked about like a key portion of COPD is those recurrent infections because the tobacco, the smoke, is destroying the cilia, so they can't actually clear it. They are one of those secretions. Increased the immune system is not either developed or it's poor at this point. Decreased activity levels. Think about that bedridden patient, nursing home, elderly that just can't get out of bed as much, or they're lazy and they spend 18 hours a day in bed, and then comorbidities. Again, that bottom, vaccinations. People get this kind of mixed up and it becomes like a political thing, and all these people argue about stuff. So vaccines not necessarily preventing disease. A lot of times it's more so decrease the impact of it, so they don't require hospitalization, they don't require as much support. So that's kind of a selling point for patients when you're talking about vaccines and why you recommend them. They're like, hey, this may not prevent you from getting this, but a lot of research, a lot of studies have shown that it's going to decrease the severity of it, so we may not have to put you on as much meds, you may not require hospitalization. Pathogenesis, right? So decreased cough reflex, they can't clear the secretions. Same thing with ciliary function. If they have a decreased cough reflex, they can't protect their airway, right? Stuff is going down the vocal cords into the lower airway. Immune antibody response, right? Maybe a comorbidity. They're on some type of chemotherapy. They're on long-term steroids, stuff that's going to affect their immune response. Exposure to particularly virulent microorganisms. So COVID was that case, right? It was just very spread very quickly and easy. Overwhelming inoculum, right? What do we talk about with that? So that's a lot at once, right? So aspiration pneumonia, somebody aspirates, all that stuff goes in there, it overwhelms the system. So it's a lot at once. And then those risk factors. So majority of what you're going to do in primary care is kind of treating diseases and conditions that'll go away on their own and trying to prevent the more serious ones. So talk to your patients, hey man, if you quit smoking, you're going to have improved lifestyle, improved outcomes. Again, those vaccinations, pneumococcal is a very important vaccination for preventing pneumonia or reducing the severity of that pneumonia. So this is just an example. You don't have to know this. Just another way of looking at it. But I will say Bob Cole would have loved this slide. So, you talk about like your vignettes. Look at your question. Look at what they're trying to tell you, right? So, and correlate that with this stuff. So, strep pneumonia, right, is the most common. H influenza, COPD patients are more susceptible to that. Klebsiella, I promise you'll see that on your pants. It's gonna be alcoholics, right? The red sputum, red jelly-like sputum, we'll talk more about that. Legionella, right? Outbreaks of contaminated water. One of my sister battalions at Fort Hood had an outbreak of this because they weren't cleaning their, the PA was signing off that the Prep Med and medics were getting the water buffaloes clean. And then we were out in the field, we were at a different training site, and we got called up that, hey, you have antibiotics, blah, blah, blah. They had like 200 people come down with that over a month in the field because of that before they figured out what was going on. So when that comes, Legionella, like it's usually large groups at once. People at like a hotel on a cruise ship, so it's the same water source. Staph, MRSA. MRSA, right, why do we get MRSA?
Too much antibiotics.
Yeah, because people, one, don't take their antibiotics as prescribed, right? My mom is super bad about this. She'll be like, I think I have some doxy left. I think I have this. I'm like, you should never have any leftover antibiotics. But she always seems to have 2 or 3 tablets of every antibiotic in her medical cabinet. She wants the, well, your dad's sick, so I was going to give him 2 Doxy. I have an Azithro. I have, I think, a Septra. And I'm like, it's not how it works. But we get that because it's either we're just shotgunning antibiotics, right? If you work in urgent care. If you ever work in urgent care, especially in the winter, it sucks because every patient, I have this, I need antibiotics. Like, now, man, you got a viral syndrome going on, or you got a viral sinusitis. I know my body. My sputum was green. That's definitely bacterial. Like, nah, man, it's not. But they'll push for you, and they'll give you negative provider scores, and they'll leave reviews on Reddit and everywhere, right? They'll Yelp you. So, but things that make them more susceptible risk factors for MRSA: recent antibiotic use, frequent hospitalizations, frequent infections. Pseudomonas, we're thinking hospital, nosocomial, right? So again, that's why the difference between CAP and HAP, right? Those things are going to increase the likelihood of viral, influenza A. You can get a ton of different virals. I had a patient at the burn unit when I was there. We used to do a lot of bronchoscopy to clear out secretions and do exams. And one of the surgeons, I was helping him out doing the bronch, and his wife, who was an infectious disease doctor, was coming by to literally just drop off his lunch. And like she walked in the patient's room, saw like the monitor, and she's like, ooh, herpes. And we were sitting there, we were trying to figure out what was going on with this patient. The patient had HSV pneumonia. So they had like the herpetic lesions on their trachea and in their lungs. So things like that does happen. They're atypicals, mycoplasma pneumonia, right? That's your walking pneumonia. So walking means it's less severe. Patients are walking around, they're less symptomatic. So the important one to know. Anaerobic, less common. Look at that, chlamydia pneumonia too. That'd be a good story to tell your loved one of how you got that. All right, clinical features: cough, fever, chills, dyspnea, right? What else does that sound like? Everything else. Your bronchitis, right? That'd be high in one of my differential diagnoses. But why is oxygenation impaired?
Can't breathe.
Is that? Okay. Think about what is actually infected now. It's the alveoli, it's the lung tissues, right? The alveoli can't do their job. They can't have that gas exchange because they're filled with pus or some type of bacteria, so it's impairing gas exchange. So that's why it's causing that dyspnea and that oxygenation gas exchange issues. Chest wall pain, fatigue, headache. On the right here we have this little chart, fever. Is fever reliable? So we talked about it's bimodal, right? So pediatrics, adult, or elderly. Elderly, you may not see fever, right? Because their immune system is not competent. They can't mount that immune response, so they may be afebrile. So just because they're afebrile doesn't mean they don't have pneumonia. So keep that in mind, right? Your vignettes, your patients. They have these other symptoms going on. Pneumonia is still high up on my list. But if it's a young, healthy person, right, may or may not have fever, most likely they're going to have fever. And then your atypical, right, we already talked about that. That's going to be your walking pneumonia. The symptoms may be milder, maybe just feeling under the weather, right? Or they're a young, healthy person and their body has a great immune response, so they're not as symptomatic as your elderly. Again, sitting 100, right? Patients come in shades of gray, so they may not have all these, but typically this is what we're looking at. And then crackles. Why are we getting crackles on hospitalization?
Settling.
So alveoli, right? So that crackles is the Rice Krispie treats that they're kind of opening up every time. The patient takes a deep breath in, with the alveoli that have all that junk in them are open up, and it kind of creates that snap crack sound. So you may hear crackles. And then you do percussion dullness. I did, if you're deployed in an austere environment without chest x-ray, you have to depend on your physical exam findings. And sitting there like in Africa, like doing this numerous times a day on the same guy, and he's like, I don't know what you're doing. You just look like crazy, but you may be able to find it. Routine labs, if you're in an outpatient setting, typically don't shotgun labs. I may do a CBC, see if there's any type of immune response, if we're having like a left shift and all that, increased white blood cells. But in the ER, they're most likely going to shotgun and do all that stuff to determine severity if the patient needs to get admitted or not. ABG, what do we think we would find on an ABG with a patient with pneumonia, say severe pneumonia? Respiratory acidosis, right? So what is going on with the CO2? It's high because they can't have that gas exchange because the alveoli are affected and they're not being able to do their job, right? Sputum samples are important too, especially if we think it's multiple different type of bacteria, or if it's aspiration determined so we can give the specific antibiotic if possible. But in an outpatient setting, we typically don't do sputum cultures unless it's indicated. Most are confirmed by chest x-ray. The chest x-ray is always going to be your first test you're going to request, right? Just a standing AP or PA lab. Right, talked about Lober, right? We think bacteria. It's diffuse, we think viral or atypical. Ultrasound, really don't see that much. You may do that in an austere environment. You can do it bedside, but I wouldn't hang my diagnosis on ultrasound, especially if I'm in a hospital environment and I have access to chest x-ray, not the standard of care. CT, right? Never the first test unless it's indicated or some specialist is telling you. It's usually just for your follow-up setting, right? CT, never the initial test, always follow-up setting. There's a classic example, right? So left lung, see this right here, kind of washed out on here, but what you can see is nice. See that clear delineation right here for the fissure in the lung, so it's that lower lobe right here. You guys will be starting ClinCore next week. A big portion of clinical correlation is what? Differential diagnosis, establishing that. Not being stuck in the mindset that before you can see the patient, and I'm guilty of this, lower back pain, right? You're going to see a ton of lower back pain, knee pain, and my initial thing before I even see the patient, I was like, oh, they're fat, and they don't want to exercise, active duty. But don't get stuck in that, so always have that differential diagnosis. Pneumonia, acute bronchitis, influenza, asthma, right? These probably wouldn't see a fever and acute bronchitis or asthma, but I may not see a fever and pneumonia. CHF exacerbation, they don't have a diagnosis of CHF, I can probably parse that out, or if they're a young, healthy person. COPD, right, again, it's that you're differentiating that. So we have to determine, we diagnose pneumonia with a chest x-ray. Now we have to determine, does this patient meet criteria for inpatient or outpatient? It's an easy trigger to say, well, we're going to admit them, right? But one, it's very expensive to admit a patient. You have to be concerned about bed space, nursing, but also increased risk of nosocomial infections, VTE, right? Having some type of thrombi because they're entering in the hospital. So I think over the years in medicine, we've gotten a lot better, right? We've shown that patients actually get sicker when they go to hospitals, right? We want to get them discharged as soon as possible so they're not exposed to all those other sick people. So practical concerns, right? Inability to take oral meds. Practical concerns too is like, saw a lot in the DOD. His husband's deployed, mom's home alone with like 5 kids, no family nearby. Sometimes you're giving mom a break and you're doing it because she has 4 other kids that she's shuffling back and forth between school and all their activities. May not be realistic that they can take care of the patient adequately, right? Or low socioeconomic status, right? They don't understand what's going on. It may be beneficial for the patient to be admitted because parents can't take care of them. New people worsening O2 requirements, typically if they need O2, they're gonna get admitted. Maybe if they're already on oxygen, you could have a little bit different threshold, but I'm not gonna typically discharge somebody or outpatient prescribe them oxygen. Most people are gonna look at you, you're crazy if you try to do that. Requirement for IV treatments. And you're really gonna need to know this curve 65 right here. There'll be another slide on it. You'll understand that. Next slide will do, and then I'll explain a little bit more. PSI, you don't need to know that for this test, but you may see that on your rotations. Every hospital is different. Every place is going to have different preferences. So the issue with the PSI is it's a huge, long laundry list to try to remember. It's actually a better test. It's more specific and sensitive, but it's a lot more intensive. So, right, get a vignette or a question, patient, they're talking about it. Patient confused, right, especially elderly. That can tell you that they're worsening. They may not be febrile, so they may just be confused, and is that an early indicator that's something? So you talk to the family member or their caretaker and say, hey, is this normal baseline? Is dad, mom, are they worsening? Can they usually have a conversation with you? So identify any of these, then we come down here and we give them our score. And then right here, we're talking about hospitalization, right? So if they have 0, likely suitable for home treatment, outpatient medications. Likely need referral if they have 1 or 2 more. So if I have an elderly patient that's confused and they're tachypnic, I'm going to go ahead and admit them. And then urgent hospital admission, right? So if they have any of these in the outpatient setting, 3 or 4, these are the patients I'm sending directly to the ER. Proceed directly there, or I'm going to call an ambulance if they refuse, and they can sort it out. If you're outpatient setting and the patient refuses, make sure it's well documented in your note that they are AMA against medical advice. Right? So if you haven't heard this term yet, you can legally defend what you document. You can't legally defend what you don't document. So make sure your notes are spot on, especially your assessment and plan. You can say, hey, counsel patient on the risk of not being hospitalized or going to the ER. They went against medical advice. Make sure that's well documented and mentioned there multiple times. Again, so this is a very intense, this is too much math for me. What we point out, we already talked about, is that pH. If we're going to get an ABG, we should have an idea of what we're expecting to see. The reason I say that is if it's different from what I'm expecting, then I have to start thinking about other things, or comorbidities, or a patient's worsening. Again, you're showing the difference in the sensitivity and the different screening tools. You don't need to know that. Treatment, antibiotics. If you can identify it or you have a high index of suspicion, you're going to be as specific as you can with that antibiotic, right? If I know that it was a witnessed aspiration, or hey, 5 coworkers were already diagnosed with Legionella. So if I have this patient, I'm going to be high index suspicion of that, and I'm going to go ahead and treat accordingly. Otherwise, I'm going to go further down. So you're going to look at all these questions, antibiotics in the last 90 days. Right? So the patient may not be a reliable historian. If you can, review their charts. Maybe they got antibiotics for something else, right? They're on doxy because they have skin infection, or they got prophylactic antibiotics for deployment or something along those lines. Age greater than 65, current smoking or alcohol dependence, right? That'll impact what we're going to be picking. And then major comorbidities. No, amoxicillin is your drug of choice. Macrolide, what's an example of a macrolide? Yeah, that's the most common. Doxy, and then if yes to any of these, you're going to go down here and pick one of these. Valactin, the 3rd generation, plus macrolide or doxy. If you think it's atypical, macrolide or doxy is preferred. So zithromycin or doxy. And then steroids. Typically not in the outpatient setting, and really where you're going to see the importance or the benefits of steroids is in really severe pneumonia. They have a lot of bacteria, a lot of inflammation. We want to provide symptom relief and decrease the severity of that pneumonia. We'll give steroids. If I'm in an osteodyploid environment deployed, I may give steroids sooner than later so that the person doesn't have to be evacuated or sent for further care earlier than later. But typically in a stateside outpatient, you're not gonna get steroids. You gotta memorize all. This is just an example, like if you go to Up to Date, we'll have like all the stuff and then they'll have a little flow chart for you as well too. Another thing is when you get to your clinical sites or wherever you're located, talk to the pharmacy and talk to the lab. They may have their own separate algorithm for antibiotics of what is susceptible in that region, right? Person may die, like Fort Wayne, anybody who came in with skin infection, we automatically assumed it was MRSA. Ranger School, infantry, AIT, kids are nasty. So they had their own antibiotic choice that we would prescribe at Fort Benning. Follow-up, again, this is documentation. If you diagnose pneumonia, you need to have follow-up in 48 hours, right? If you don't, a person stays home 3 or 5 days, or they don't come back at all, the patient dies, they're gonna come after you. But we wanna see and intervene sooner than later. So 48 hours, if they're not improving, that should make your spidey senses go off, that either this is maybe an atypical bug, maybe it's not pneumonia, maybe it's not bacterial, and that may change the escalation of care, right? So I may say, hey, I'm gonna go ahead and transfer you to the ER, or I may call pulmonary or the MOD, and say, hey, I have this patient that's not improving, come in there. Repeat imaging, so serial x-rays, that first x-ray may not have shown anything because it hadn't consolidated enough, so you get a repeat x-ray if you're concerned. You could also do a CT, but if it's otherwise healthy patient, I'll probably just do chest x-ray, but CT is not incorrect if your spidey senses are going off. But additional imaging is not indicated unless concurrent disease is ruled out or findings suggestive of concurrent disease. Chest x-ray, will we say this, how would we describe this? Right or left lung? Left lung, is it lower or
Lobar.
right? Which lobe?
Upper.
Is it upper? This is upper. Is there delineation? Say, I could also say maybe this is the whole lung, but you see delineation over here. Admitted. So this is not a hospital-acquired pneumonia. This is community-acquired pneumonia that you made the decision to admit, right? Clear delineation. They got this out of the hospital. They weren't in a hospital facility or a medical facility, no dialysis, no nursing home. We admit them, we're going to give them these medications. So I'm not going to test you on this. This is more so for FYI, so you can be exposed to it. But if we're admitting them, typically we're going to start antibiotics IV as soon as possible. Get cultures in the ER that may do sputum cultures. Treatment minimum is 5 days. That doesn't mean they necessarily have to stay in the hospital 5 days. If they're improving, they may be able to move them to outpatient setting. I've had outpatients that I've had to give IV antibiotics in clinic for. If it happens, typically if that happens, they're going to coordinate care in advance. They're not going to just dump that patient. If somebody does dump a patient like that on you, that they just walk into the clinic one day and they say, hey, I'm supposed to get IV antibiotics from you. You start making phone calls and start getting people held accountable because that's bad medicine. Then there's another flow chart. You don't need to know it. Nosocomial infections, right? So now the clear delineation. You can kind of classify it into these three: HAP, FAP, HCAP. But the clear delineation is 48 hours after admission. So FAP drives me crazy, right? Because a lot of times it's preventative. Ventilator-associated pneumonia. Number one reason why they would get that in the pre-hospital setting is what? What's that? Oral care. Most likely it's going to be the intubation itself. It used to drive me crazy when medics would preload like their ET tube with a stylet, like it's going to save time. Like, dude, all 2 seconds that has saved you. But they'll open up. Paramedics will do that. Or if you go in the back of their ambulance, they already have the ET tube open and the stylet put in there. But think of all that crap that's on there, right? That's sitting on the ET tube that's getting in there. So it's not a sterile procedure, but it's a clean procedure, right? So you shouldn't be doing that, and we're very guilty of that. I've taught a lot of pre-hospital medicine. People, the medics are always, well, we have antibiotics for a reason. Like, nah, man, that's a crappy excuse, right? Just because you're a pre-hospital doesn't mean you do bad medicine. So think about that if you're deployed to austere environment. Antibiotic use, right? Have they already been on antibiotics? Are they on chronic antibiotics? Have they had other infections? But these are bugs that we're concerned about for nosocomial. right? What's Klebsiella associated with?
Drinking.
Alcohol, right? Klebsiella loves its cocktails. So again, talk to your patients, ask them recent hospitalizations, healthcare associated exposure, have they had to been going more frequently because they've had some suspected disease and they've been going to the hospital every day for 2 weeks for serial exams or serial testing. Signs and symptoms are very similar to our community-acquired pneumonia. My experience, are typically worse, right? So typically, community-acquired pneumonia is bad. Hospital-acquired pneumonia or nosocomial, typically it's going to be more severe. So CBC, if I said there's a left shift on the CBC, what does that mean? Right? So in the phase 2 sites, when you get there, you want to sound smart, be like, I see a left shift on the CBC. And they're like, oh, all right. Whereas if you say it's increased neutrophils, they may be like, okay, you don't know what you're talking about. But CBC, blood cultures, sputum cultures, SpO2 and ABGs are going to show declining oxygenation because as the alveoli are infected, they're not able to do gas exchange. And if suspected, patients will typically be readmitted. These are the antibiotics that we're going to be going, right? Beta-lactam, coverage penicillin, anti-pseudomonal activity. Typically, once they're inpatient, then those cultures, you're going to get them back from the lab and you're going to make recommendations of what antibiotics, or you'll consult with ID. When we say consult or refer, that doesn't necessarily mean they come and examine the patient or patient goes to them. Sometimes that can be a telephone consult or a telephone referral. A lot of times infectious disease doesn't need to see the patient, they just need to review the labs, review that. And they'll be like, oh, based off these findings, this is what I recommend. But again, you're going to share liability, get names on charts, so you're not the only one holding the bag at the end of the day. You don't need to know this, but it's just another example of that flow chart. Aspiration pneumonias. This looks like half my family of the holidays. Pretty sure I have pictures of my uncles and cousins in this exact same position holding the bottle. Aspiration pneumonia is scary, right? All that stomach contents is coming up, or they coughed, they inhaled something that wasn't air, right? So food, drink, number of things. Had a patient on deployment, they brought him in there, and I opened up his mouth, and we were going to intubate. It was the infantryman, and it was just filled with Copenhagen. It was the nastiest thing, so I was like trying to lavage it and trying to get it all out. But I'm pretty sure if that guy got secondary pneumonia, it'd be like the first one for Copenhagen-induced pneumonia. So anything that's in their mouth, right? Make sure nothing gets in there. Witnessed aspiration, right? You're sitting there talking to somebody, they take a drink or they do something and they start coughing uncontrollably, and they have difficulty breathing, kind of a classic aspiration. Swallowing difficulties, right? So maybe they have some type of paralysis, ALS, or some muscular disorder that's causing that, under the care of like a speech pathologist for their swallowing issues. Altered consciousness, think about that alcoholic or that drug addict who's on the side of the ditch or on the streets that is kind of coughing, but not really able to communicate with you. Polymicrobial, right? So anything that was in their stomach is now in their lungs. And that's very concerning because look at that pH. Doggy. That's 2.5 acidic. That's going to cause all kinds of problems. But if we think aspiration pneumonia, we're going to treat for that polymicrobial. So we're going to be a little bit more aggressive. Again, Klebsiella, alcoholism. High fever, this is a pretty quick onset. This isn't like days to week. This is typically hours for this type of consolidate. Probably consolidates pneumonia in hours. But know that Klebsiella, another key feature of that is that red current jelly-like sputum. If you ever get a test question like that, patient's coughing, they have a red jelly-like. If they get Klebsiella, that's going to be pathognomonic for that. You can see it on your pants. Rapidly consolidate, this is very aggressive. Location depends. So if a patient's supine laying down, where would we think on a chest x-ray we would see it? Everywhere. Everywhere? Okay, fair enough. Typically, if they're laying supine, like flat, we're thinking upper lobes. If they're kind of sitting up, like 30 degrees, probably thinking middle, lower lobes, right? So just think about that. More so important is if they're laying down completely flat supine. If any of those patients are high risk for aspiration, they shouldn't be laying supine. They should be head of the bed elevated somewhat, 15 to 30 degrees. So think about that when you're looking at your patient and kind of the history. High risk of lung abscess or emphysema. We'll talk more about those, but these are high risk factors associated with aspiration pneumonia. So you think this patient's like an outpatient setting, just saying, I have a little bit of shortness of breath, I'm coughing a little bit?
No.
This has been going on for a minute, and this patient is very sick. This is not going to be a patient that's just talking to you, having a normal day. They're going to be in a lot of respiratory distress and having a lot of issues. I'm surprised the chest X-ray doesn't actually have them intubated. This would be a very ill patient. But think about, again, gastric contents, that acidic contents from the stomach comes down, trachea, goes into the lung. What it's doing here. So this is an infection and that pus collection in the chest cavity outside the lungs. This is very, very severe. I've never seen anything like that in an outpatient setting. Typically, if they can get away with it, they'll do a pigtail catheter, which is kind of like a chest tube, but it's more targeted, it's less invasive. Chest tube is very, despite the number of times we do it in the DOD, it's an invasive surgical procedure that most patients don't like. So in a hospital setting, as long as the patient's semi-stable, they're going to do some type of catheter and not a chest tube for this. If it's big like this may be going to the OR, so the surgeon can clean out. So management, if you have a high index suspicion, I would get these patients to the ER sooner than later. Try not to manage them in the outpatient setting. Early blood and sputum cultures, again, that's likely going to be done in the ER or immediately upon admission so they can identify it. Give antibiotics very early and empirically treat for CAP and nosocomial pneumonia if there's aspiration concerns. O2 supplementation, right? These patients are typically going to be very ill. Anaerobic coverage no longer treated, and if it's abscess or emphysema, some type of surgical drainage, right? So incision drainage, surgical drainage, chest tube, pigtail catheter, something along those lines. Influenza, so we've just seen a big spike of that in the United States, especially here. Patients would be upset, like, well, I got vaccinated, it didn't work, right? Again, it's education, that's fine. Vaccines don't necessarily cover 100% prevention, but it increases severity. You got to re-emphasize that to your patient. Incubation period, 1 to 4 days, and then they're going to have these symptoms. Typically, with your influenza pneumonia, it's less severe than bacterial as far as patient presentation. Bacterial presentation, patients appear a lot iller. Got more complaints, aren't doing as well. They may have some body aches associated with influenza. They may also have that upper respiratory stuff associated with it that you may not see in pneumonia. So what does poor sensitivity mean? In practical terms, right? I don't want like this, I'm not that smart, all right? It's a big debate right now. If you think poor sensitivity in this test, what do we think in practical terms? It means patient's sick and it's missing it, right? Patient, you're looking at them, you're like, you for sure have this. You test them and it comes back negative. So it means you're missing a lot of tests, a lot of false negatives, right? So just simplify it that since poor sensitivity means patient's ill and the test is missing it. So if you still have a high suspicion, this isn't going to change my game plan, but you got to consider it. Chest X-ray, usually it's going to be what? Is it going to be lower or what? It's going to be kind of everywhere, right? Majority needs supportive care. Tamiflu is one of these things, everybody wants it, right? The reality of it is it's very expensive. If you're working at a military treatment facility, they have limited numbers of it. There'll be some cases, even at like outpatient hospitals outside the military, where they're going to limit to, you put that order in, pharmacy screens it, and they'll be like, well, they haven't met this criteria for your charting to indicate for this. So It's not uncommon for you to put a medication in, you can assume it gets approved. Pharmacy can still override you and say, hey, for the hospital commander, the deputy commander of clinical services, chief of pharmacy, we're gonna limit Tamiflu. It's not indicated for anybody that's had symptoms ongoing. So, 1 day improvement duration, but you wanna give it as soon as possible. So maybe 2 to 3 days. If you wait for like a week and then you get Tamiflu, you're not gonna get any benefits from it. So, 1 day improvement duration, no change in severity. So the squeeze worth of juice, maybe, but typically they're not going to get big benefit of it. Can they have side effects of Tamiflu? Yeah, you can get nausea, vomiting is pretty common, GI symptoms, headaches. So it's not just a benign medication you're given, so keep that in mind. But if you have these comorbidities, strongly recommended that you give Tamiflu. And down here, do not prescribe no clinical medication with symptoms that go on greater than 48 hours. Now this is the random one that's not pneumonia, but it's thrown in here. Pertussis. Anybody here ever had a kid with whooping cough or had whooping cough? Very distinct, right? Should miss this test question because what is the bug that causes it? Pertussis, right? One of the freebies right there, right? There is a vaccine for this. It is bacterial, but it's essential. So we highly recommend it in high-risk populations, pediatric patients where there's increased likelihood of that. Fevers are variable. Again, they may not have the immune system to mount the immune response to give them a fever. But this is going to be our diagnosis right here. So they have to have a cough lasting 2 weeks and one of the following. So again, patients come in shades of gray, right? You may not get all 3 of these other symptoms, you may just get 1. So that cough, it's a very distinct cough. They take a deep breath in, it's multiple coughs on inspiration. It's not just one. You gotta have like a Woody Woodpecker, have that stutter cough going on. Expiratory whoop. Remember whoop, there it is. Kind of like that. Very distinct sound. You won't see that as much, honestly. As you will the coughing, that stutter cough. And then post-tussive emphasis, right? They get so violently coughing, then they throw up afterwards. And then the phases of these, right? So federal phase, 1 to 2 weeks, those are non-specific. You may just say patient comes in that first 1 or 2 weeks. If I say bliss, rhinorrhea, mild cough, what are we thinking? I don't say even to this day, I'm going to be like, well, most likely it's a viral URI, right? Supportive care, here's some Tylenol, we'll manage that. Patient comes back after 2 weeks, now they have that cough or that whoop. That's where we're going to be finding it, is after 2 weeks, and that's key for diagnosis. And then that convalescent phase, week 3 to 5, so maybe prolonged, gradual reduction of cough. So you have to counsel the parents, counsel the patient that we're going to treat you, but this isn't going to go away overnight. We may have this for residual for a few more weeks. So this be 3 to 5 weeks. Would that fall in acute, subacute, or chronic cough? You guys already forgot last test. Right? So key down here, patients with prior immunity, right? They got the vaccine, or they've had this last year. They may not have all these classic symptoms. Limited suspicion if they have that diagnosis in the past. So get a medical history, look through their chart, and see if they had this in the past. If they've had it in the past, or they've had the vaccine, it may lower my threshold for diagnosis, and I'm going to consult with specialty care if it needs to. So labs, we can do swabs, culture for PCR. Typically the first 2 weeks, because that's when it's going to be most prevalent. But what's interesting about this, we're very aggressive with post-care and exposure, right? So there's not a slide, we'll talk more about it. But anybody in close contact, parents, other kids at school, if you're in a healthcare setting, you may be treated prophylactically. So they've had a cough lasting 2 weeks, we don't need to wait until they have those other symptoms. We're going to treat empirically, okay? Supportive care, points of coughing triggers, right? So we don't want the kid playing outside if it's cold or doing anything that's going to worsen those. We sucks for little kids, right? They want to get out there and play with their friends and be active. We have to keep them inside. It sucks for the parents even more. Macrolide, azithromycin, especially less than 1 month of age. Azithromycin, less than 1 month of age. Azithromycin, less than 1 month of age. All right, what's another name for this antibiotic? What's the trade name? Septra, Bactrim, right? Maybe your secondary medication. Mission considerations, pretty straightforward. Age less than 4, we're going to admit them. Typically, we admit these patients, they're going to be on isolation or in a single room. They're not going to be with the patient. Now, 2 kids have it, then all bets are off. You just throw them in there and they can have a coffee party. So post-exposure prophylaxis. So this has happened to me at least twice in ERs that I've worked in, where some kid came in with just coughing everywhere, blah, blah, blah. They make the diagnosis, then they come back and are like, all right, everybody's going to get treated empirically because they don't want healthcare workers getting sick, spreading it, or more importantly, like it happened during COVID when you had neurosurgeons like doing primary care. You had like orthopedic surgeons working ICU. Healthcare employees get sick, right? They can't come to work, so now it's all hands off. And you're like, hey, janitor, know anything about nursing? Come on over here. Right? So we may be aggressive with this stuff, close contacts, like family members, kids in daycare, school, healthcare employees, all that good stuff. Then usually you're high risk that you're going to be very concerned about. If it's younger than 1 year old, pregnant women, right? So typically takes care of the little kids, it's mom, pregnant with the next kid, they're increased risk for spreading it and getting it and having morbidities associated with that. Persons who have contact with infants, so daycare employees, school teachers, persons with immune deficiency, right? Like during COVID, I went to a friend's wedding. His mother was undergoing chemotherapy. She sat like 50 feet away with like a mask and was like the bubble boy the whole wedding. I felt bad for her because she wanted to. And it was weird that they didn't really execute it well. They tried to do a first dance. And she sat over there and they did it and they did like this weird, like this was like out of a movie. It didn't really go off well. It just looked like 2 people awkwardly dancing 50 feet apart. All right, any questions about this? So again, I'm showing you straightforward. Pneumonia is going to be the probably the most test questions are coming from this slideshow. You're going to see a lot of this in real medicine and in your face tubes. All right, so let's take 10, and then we're going to knock out TB.
Switcheroo. We're getting ready to go down and get a haircut. Come on. Oh, man.
I was like, Jim, drop. Where are they dropping? I walked out the room. Yeah, I hear you. She wouldn't say it. I'm like, tell me what you say. And then all it was, she couldn't find her phone. That's what she couldn't find. And I tried to give her what it wasn't. She didn't know. Turn on all the lights.
It's also like 40 minutes away. Well, no. What do you mean? I don't talk to
She was three of them, like, you're so I know, yeah, it would have rather what she did, she
the radiology said that. They said everything was good. Bags on.
Oh, no, I said exactly. What I said exactly.
Yeah, he said that.
She shit everywhere. I got
They were trying to get you.
just a little. Walk away from the
The first one, you work on something as a group. That's
That's when she first made her. And then
you just need to do it like it's just
how can you see that on an X-ray? That makes no sense. I can't see that on an X-ray. See, to me, I don't think you cannot see that. You would have to be on MRI to see if it's not.
So you get a
well, yeah, the eyes.
It's just Saturday night.
Why do you talk after that? As soon as are you okay? It's like
spinal process. That's what I
am not noticing.
yeah, like if you give me an X-ray, I usually hire that radiology. Why so much?
Busy.
how should I first yeah, I literally
Does. It's been helping. Yesterday.
yeah.
I did go to the got home, and then immediately got ready, went to the gym. I Yeah, and then I did some practice questions as it was. Sorry, I didn't know that you allow it. Exactly, VIP room. Yeah.
So 30 something slots. Huh? It's only 30 something slots.
All right, ready to get started? All right, I just gotta emphasize and clear something real quick. In no way, shape, or form do I condone shaken baby syndrome. I do not want CPS called to my house tonight. Like Mr. Rakowski is, you can check on his baby. If I do, I know it's one of you guys. I'll hunt you down. Fine.
That is on YouTube.
Yeah. Tell that to YouTube.
So I want to push forward and get another thing knocked out because you guys haven't been in San Antonio when there is a threat of a snowstorm or anything. It's about to get crazy out here. Why? If you ever got me fighting over the dumbest things, like, ah!
Toilet paper.
What's that?
Toilet paper.
Yeah, you steal it from the bathroom.
Good thing that. Toilet paper
I would say,
is
I was here about 6 years ago when there was a snowstorm. By snowstorm, it was
Snowmageddon.
literally like an inch.
That was bad.
Within like 15 minutes of it happening over 410 where the North Star Mall is, there's that off ramp. There was like a 20-30 car pileup in like 15 minutes. I promise you, it gets crazy. So stay off the roads because they already suck driving here and you throw snow in, it's even worse. All right, so we're going to be talking about TB and myocardial pneumonias, right? So TB, seen it less in the United States. We've got a lot better at treating it. But we never fight and never deploy to like really nice places. You don't see like New Zealand popping off or Ireland or anything like that. It's typically places where people are unhappy to start off with. Good thing we're not going to war with Greenland now because they actually have pretty high TB rates. So we got that going for us. Yeah. Mitochondrial, we're talking about fungal, right? So TB. Those immigrants, my family, right? They brought TB to the United States. So that first, 1882 was when it was first actually discovered that it's a bacteria. Whatever some names they used to call it back in the day. They had the consumption, right? They'd also call it like a wasting disease. At the time, 1 out of 7 deaths was TB. What was the royal touch? Anybody know this? It's like a history. You're not going to be tested on this. It's just something.
Made you skinny.
Like a priest thing. Oh, yeah. So back in the day, especially like England and France, they thought royalty could touch you and cure it, right? If you got in line, you could go see the king, queen, or prince, princess. You literally just stand in line. They would do like some little hand waving, and you'd be cured. Wasn't ever FDA approved. It's found out in favor. It was found not to be really beneficial. But patients flock to Denver for dry sun, right? Anybody ever seen Tombstone? Right? Where does he die? He dies in Colorado. You can actually go visit his grave and where he stayed. Well, they don't know where he's buried at in the thing. They just have a random gravestone there, but they say he's not buried at that spot. He's buried somewhere else. They used to give you a pneumothorax to treat it, which that would have been fun. You just stab some patient, and you'd be like, all right, you're cured. Mid-20th century, antibiotics were introduced, right? So first antibiotics, it was like 1910. It was a synthetic antibiotic, didn't really ramp up till the 1940s. Penicillin was discovered in the late 1920s. But around World War II, we saw just a surge in it, and we actually were able to start treating these things. Highly treatable in USA today. Biggest issue with TB treatment is it's not a quick process. It's not a Z-Pack and you're cured. It's months and months of treatment. And patients are non-compliant. We'll talk more about that and why that is a concern for us. Who's that on the left? Doc Holliday. Why was he Doc? He was a dentist in addition to being a gambler. So imagine that guy working on your teeth, coughing up blood. So he wasn't a dentist very long. And then on the right, I don't know who this person is, I don't have a good story, but talk about wasting. So look on the left, look on the right. So this is when she actively has the disease, your chest x-ray. This is right post-treatment, and her lungs are cleared up for the most part. Some of this, you're never gonna have necessarily a complete resolution on their lungs. They may have some continuing scarring. Some of the granulomas just cause permanent nodules on the lungs. Right, so very unique about TB is it has 3 different phases or stages of the disease that we'll talk more about, but it's a unique feature of this that you have to really understand to be able to treat it, diagnose it. Cause that, there's the bug that causes it. There is a vaccine for it. We don't routinely use it in the US because it's expensive, it's not common, and we have a low risk in the United States. But look at that map. For work duties, I've been to at least 10 of these countries. So again, right, Africa, we do a lot of stuff there. Iraq has a higher incidence. Thank God we didn't go to Greenland, right? Look at that, we're suffering. What do we see over here? Some of you guys may have been there. Afghanistan, look at this bad boy. Somebody's been there. Mongolia, right? Right, we go to war with China. We're going to be all of these areas, like World War II. These are countries of higher incidence. I'm not going to test you like, what is the percentage in Nigeria at this time? So I kind of understand trends, right? What's another trend in these countries that we're seeing? They're undeveloped, right? Poor, you may hear the term third world. Third world country, I hate that term. For public health, third world term was coined for communist countries, right? So third world country was a country that was not aligned with the Soviet Union or United States, Western forces. So more appropriate term nowadays, especially in medicine, when we talk about public health, global health, is undeveloped countries versus developed. Third world countries kind of fallen out of favor. So risk factors, right? Again, go back to those countries we were talking about. Undernutrition, there's a lot of undernutrition in Africa and developing nations in Asia. Diabetes, HIV infections, rampant in Africa. Alcohol use disorder, smoking. So a lot of these, it's kind of ironic that the poor people spending all their money on tobacco and alcohol. Back in the day was you were very wealthy if you smoked and drank. Talked about that. So the pathogenesis, the infection, you may not know it because typically during this, patients aren't symptomatic. So they inhale some type of contaminated airborne droplet, and it's years later before we diagnose this or they actually show any active symptoms. So we have a low index of suspicion in the military. That's why we screen people with PPDs, because we travel a lot of these countries where it's either undiagnosed, underdiagnosed, or not treated, and people just have it. So immediate reaction, you inhale this, macrophages phagocytize the TB, right? They engulf it to try to eliminate it. Then we get down to our stages, right? So primary disease, some of that bacteria escapes the macrophages, and it disseminates into the lung tissues. You may see some incidental findings on chest x-ray, most likely, unless you have like a low index of suspicion, maybe silent or show some small patchy opacities. We could also say that just an incident of pneumonia, most likely if we don't have like a history that goes along with it, or know the patient's recent travel history or where they came from. So primary disease, that's the beginning, right? They inhale it, some gets out of the macrophages, and it's silent in there. So if you do a PPD, we'll talk more about PPD, but that's the common screening test. They're not going to be reactive, and their chest x-ray is most likely going to be silent. Now where we start to care is latent infection, right? So this is where that live TB, it may be years to lifetime. So a lot of these patients, the majority of them are never going to actually progress to reactive disease. They're going to stay in this latent infection. So they're non-symptomatic. but they're gonna start to develop some things that we can find. So chest x-ray, the granulomas, basically bacteria walls it off in the lungs and creates it. So, or nodules. Nodules is that benign term. You're gonna see in primary care, as a patient goes to the ER for something, they got a chest x-ray or they got a screening exam, they were doing like a dye physical or something like that, and they had to get a chest x-ray, and they find an incidental nodule. Scares the shit out of patients. So they come to primary care, they said to follow up with you. So what do? You have to further work it up, and you have to calm your patient down and be like, majority of nodules are not cancer, majority of them are just incidental findings, and you have to work it up. But if I know a patient comes in, they had a routine chest x-ray, they had a nodule or granuloma, and I know they recently traveled or deployed to Mongolia, somewhere in Africa, it's going to lower my index of suspicion, and I'm going to be more aggressive with this and be like, we're going to evaluate for that. So this is also where we see our PPD become positive. So again, understand test question, where could you see a positive PPD? It could be your latent infection or your reactivation disease. Most likely we're reactivation disease, that's when they're symptomatic. We're not going to do a PPD because we're thinking TB at this point. We have other diagnostics. But latent infection, that's where it's going to start becoming positive. Reactivation disease, and again, this is the minority of these patients with latent. I think it's like 5%, up to 10% are going to actually convert to this active disease. This is where your patient is symptomatic, right? And then early reactivation, immunosuppression. So, what would be some classic examples of immunosuppression? HIV progressed more so to AIDS. HIV, like early diagnosis, you may not see this. Cancer patients on long-term steroid use, diabetics, along those lines. And the classic findings for the chest x-ray, hilar lymphadenopathy, right? Especially in the upper lobes. Signs and symptoms. So active TB is typically, we have that when they come in with the active symptomatic, that's when we're going to make the diagnosis, unless we were doing PPDs and screening. If I gave you just these symptoms, what else? Weight loss, fever, night sweats, what should be high on your differential diagnosis? Cancer. So those are what's coined in oncology as B symptoms. So if you get that patient, you should be very concerned about it being cancer as well, so have that up in your differential diagnosis. Initially, it's going to produce as a dry cough. Then as the disease progresses, we're going to see that more productive and purulent with time. And then that classic blood streak sputum, right? You see that like in Tombstone, those older movies, the guy has like a handkerchief, there you go. My dad still has one of those too, it's disgusting. They'll hand it to you, and I'm like, oh man, I don't want that shit. Give me a piece of cloth that other people have been coughing into. But they'll cough into it and there'll be blood streaked on there. This may be subtle than dyspnea, right? If it's early on, maybe not doing too much of that. They may be only dyspneic when they are coughing. Physical exam, again, going back to that picture of the wasting disease. If they're in this active, most likely they're going to be chronically ill, malnourished. Their metabolism is very high, trying to just stay alive. They're coughing a lot, so they're going to be thin. Wasted looking disorder. Lung exam, non-specific. Miliary tuberculosis. So miliary looks like millet seeds. It's like these little pellets, and that spread through the blood, right? And that could be in the liver. It could be throughout the lungs. It's a pretty unique X-ray. It looks like just speckled, like you took paint and you flicked it out there, and there's like little white spots all over the lungs, and that's miliary TB. Still treated the same way, it's just kind of an incidental finding or another presentation. So, if you suspect TB, isolate, right? So the person's got an N95 mask on. This guy feels horrible because now people are presenting, he looks like he's from outbreak, right? So, this is for active disease, right? So, if we're concerned about that, this is the labs that we're going to do. Sputum samples, 3 consecutive mornings. We're going to do those cultures. So, most likely you've already started treatment if you have a high index suspicion of this, right? We're going to go do it because the cultures can take up to 1 to 8 weeks, especially if you're at a smaller facility that has limited lab capabilities. That's another reason for it being undertreated or underdiagnosed in developing nations. They don't have the lab capabilities. Have you guys seen the rats that they're using now for TB? You know the rats, those big giant ones that they put out into the minefields that are trained? They're training them for TB now too. So you can sponsor them. They're kind of cute. I hate rats, but these are cute. They're just giant, they're like small cats. But they're training them in developing nations, especially Africa, to sniff it out and be able to detect TB sooner or later. I don't know the sensitivity or how specific it is, but you see weird things online and you get into rabbit holes where you're supposed to be like looking up something important, and the next thing you know, you're looking up rats sniffing out TB in Africa. That's how I spend my evenings. Chest X-ray, right? This is very important to know right here, right? Primary phase, you may see something, most likely it's going to be unspecific. Pleural effusion, you may think this is just atypical pneumonia. Now, latent phase and reactivation phase is where it gets interesting. This right here, Gone lesions, is pathognomonic for TB. So in any test question you ever see, Gone lesion, or they classify it as a calcified shell, we're thinking TB. Again, calcified shell, Gone lesion, TB. Reactivation phase, remember this is where they're symptomatic now, they're coughing, they're having that wasting disorder. Apical infiltrates right here. So this person most likely is in the reactivation phase or the active TB. You see that up here? This is the Gone lesion, this guy right here, this little eggshell. Look at that. So it goes up to the upper lobes because it likes oxygen-rich environments. Typically when you're breathing in, there's less thing in there, so you're going to fill up your upper lobes before you do your lower lobes. All right, a lot of words on here. This is the task force recommendations of who should get screened. We do a pretty good job in the military, especially like post-deployment. If you're there at the SRP site, you're going to get screened with PPD. What I want to do, if I'm screening my personnel in my unit, I want to do PPDs like on a Monday, Wednesday, or Friday, right? Because it has to be reviewed within 48 to 72 hours. So never order these like on a Thursday or like before a 4-day weekend because you're screwing yourself, right? So kind of think accordingly when you're doing these for your guys and gals, is that you're 48 to 72 hours because I'm not coming in on Saturday and Sunday, right? So do these appropriately. What it is, it's a subdural injection. We've all had them. We'll talk more about the diagnosis of it. But false positives, right? Once positive, always positive, or the vaccine. So I had a case like this at Hood where a guy got the vaccine without telling us. So we didn't provide it. He was like, well, I'm going here. So he went off post, got the vaccine, came back, we deployed, he got PPD, and it came back positive. And I was like ramping up. I was like, all right, you're going to public health. And we were getting ready to start treating all this stuff. And then a nurse at the public health center said, hey, did you know this guy got a vaccine? I was like, no, because my patient lied to me. They're all dirty liars. So it made me kind of look like a fool. But talk to them about it. If they ever got the vaccine, it may not be in their medical records. They may have gotten it because they were travelers or they came from another country where it's commonly given. False negatives, typically that's going to be poor technique, current infections, some chronic disease. And then we're measuring the induration, the swelling, right? Not the color. So most of the time I'll just close my eyes and trace my finger along their skin. Because if you look at it, you kind of get fooled. So you're feeling it. You're not looking at it. Another test right here. Quantiferon Gold T-Spot. Very expensive. A lot of places you can't order it, but it is actually a better sensitivity and it's more specific for TB. But it's not a good screening tool because of that. It's very expensive, so you can't order 700 of these and expect the lab to be able to do them. But PPD, give me a few medics, I can knock out 700 an hour or two, right? That's how you administer it. So after you administer it, tell the patients not to scratch it, try not to rub it, try not to be irritated by it, anywhere in tight-fitting clothing, because that can also give you a false positive. So, remember, 5 millimeters, why would we say 5 millimeters for all these people? What's common about all these? Immune immunosuppressed, right? So their immune system may not be able to mount up large enough, so you can get false negative, false positives. Is that if you go off 15 for everybody, if your immune system's weakened, it doesn't have the responsibility to be able to respond to that. And so you may get, well, this is 5, so you don't have it. So think that 5 is for your immunocompromised, 10 is going to be for your high-risk personnel, some immunocompromised, recent immigrants, IV drug users, must be HIV negative, right? Doesn't mean they don't have a weakened immune system or have some other stuff going on, but we're putting this on high risk. Everybody else is 15. So if I said somebody just had spent a year in Afghanistan, would you put them here or here? Yeah, so also if you have questions about this, very rarely are you going to be treating TB on your own or diagnosis. If you have a diagnosis, it's going to get either seen by infectious disease or public health command, and they're going to guide treatment for you and management. So they may go ahead and order this test if you have a questionable PPD or questionable history. They may go ahead and order that, but you're not going to do that for every patient. But have a general understanding of this, of PPD, and how that's going to affect your response when you're looking at your patients. If you have a vignette that says, hey, IV drug user, no known HIV, you gave PPD, is this size, along those lines. Right, so Bob Cole, I guarantee would have loved this slide. So principles of treatment. Biggest thing with TB is compliance with the medications. So they don't take appropriately. Now we start getting resistance to that. We see that that's a common issue in the United States. Number one reason why patients don't take medications is because it's a difficult way of prescribing it, right? If you say, take this medicine 5 times a day with eating, are people going to be compliant? No. So you think like, again, I talk about a Z-Pack. Why everybody loves Z-Packs is it's once a day. I can get a patient to take once a day. The more frequent you make it, the less compliant they're going to be. So we want to look at the one that's going to be most realistic for our patient. So public health typically are going to guide your treatment selection for this. It's not something you're going to be doing in a vacuum. You should be consulting with them. And typically, whenever you order or you put a positive PPD in medical records or Genesis, it typically generates automatic referral or notification to public health, and they're going to be on their radar as well. So active TB, right? Which phase is this?
Primary.
So active TB means they're symptomatic. So which phase is it going to be?
Reaction.
Reaction phase, right? So right, it's going to be for 6 months. Again, that's a big reason why people are not compliant with this. Are these medications going to have side effects? Yeah, some people just don't tolerate medications. So they may be non-compliant, they may be telling you they're compliant, but it's a long duration. So intensive phase, all 4 drugs, so if they're very symptomatic. Continuation phase, you're going to continue those 2 drugs for the next 8 weeks, usually INH and ribavirin. But if I tell you a patient's active TB, think right for 6 months. And if they have resistant TB, again, so non-compliant, or they're in a country where part of the issue with like global health stuff, NGOs, they mean well, but what happens? They go into a country like we're going to fix everything, then they lose funding, the country goes sideways, government collapses, they have to leave, they don't have continuation medication. So they started a whole village on TB treatments, they're 2 months into it, country collapses, or they lose funding, or they have to leave. So think about that in the countries that we're going to. We don't go to like happy, healthy countries typically to fight wars, right? It's usually the government's collapsed, public infrastructure is collapsed. So you may have a lot of patients that got started on treatment and then they go months without any medications. Now you're going to have resistance. Latent TB, so which phase? The latent, right? So this is going to be symptomatic or asymptomatic? Typically asymptomatic, right? You're going to have a positive PPD with non-active chest x-ray. If they have an active chest x-ray, we're going to go ahead and treat them like active TB, okay? So look at these before I talk about them. Preferred or alternate? What kind of stands out?
3 months.
What?
3 months versus 9 months.
Yeah, so the first one, right, INH, it's one medication, it's not too bad, 6 to 9 months, right? Versus the poly right here with 2 different medications, INH and rivampin, is only 3 months. So again, this is where public health comes in to kind of guide your treatment. That may be the quick, easy button, it's only one medication, but 6 to 9 months versus 3 months, compliance issues. So use what is appropriate for your patient. These are your baseline labs. So can tuberculosis cause anemia?
Sure.
Could it? Yes or no?
Yes.
Why could it? What?
Coughing up blood?
I'm not going to cough up that much blood. So you'll learn more about this in senior anemia of chronic disease. It used to be called anemia of inflammation. Somebody's chronically ill, that suppresses their ability to create RBCs. So you could also see in somebody long-standing TB, anemia of chronic disease. So you want to do CBC. You also want to see, are they mounting an immune response? Is their immune system actually working? Or did maybe you're finding some other comorbidity that might affect their TB treatment, TB diagnosis. CMP, right? So TB, like I said before, can spread, biliary TB, so it can go to their liver, it can go to their kidneys. We want to know about kidney function. That's also important because duration of these medications, right? You're putting somebody on something for 6 to 9 months, you need to have a good baseline. If the baseline is normal, you don't necessarily need to repeat it, but if it's abnormal, that's going to dictate your treatment plan, and you may have to change it up and do serial exams or serial labs. Then HCG, right? Just as a blanket rule, if you have any woman of childbearing years, even if it's just for like the most benign thing, do an HCG to cover yourself, right? If you're doing any treatments, HCG. Other labs required for specific anti-TB meds, we'll talk more about that. And then compliance. Again, I'm going to keep stomping my foot. This is the #1 reason why we still have issues with TB is compliance because of duration of medications. So Fort Bragg, I actually had to get a command order put in there for the patient to report to public health every morning after PT to watch a nurse take their medications. So it's a big issue for compliance. So this is where you get your command team in there, or public health officials, to order that person to take their medications and show up every day. You counsel them, you put in there, and in fact, the hospital commander may even order it too, as well. If you have a high-risk individual that's not taking their medications, concerned about it spreading in the barracks, so make sure your patients are compliant. You don't need to know this for the test, but it's an example of additional monitoring and stuff that you're going to get. So peripheral neuropathy, what would we prescribe with that? Yep, we already talked about that in the previous slide. And the additional labs that you may request. And again, public health is going to walk you through this. You're not going to be left alone and afraid with this. All right, so now we're going to get into our fungal pneumonias. This is actually a pretty cool one. So, out in the United States, right? You're going to see this outside the United States, but we're really focused because we're talking about primary care in the United States. So, histoplasmosis, where's that about? Are we in that zone? Histoplasmosis is not just the blue, it's the overlap of these things too, right? So it's all the way through here. There was a big outbreak a while back in Austin. Why Austin of all places? Bats. Have you guys done that yet? Lake Travis, they have the bridge. You can go underneath there and see the bats. They also have like these tourist activities where you go into caves in Texas. So be careful what you do in your free time. But histoplasmosis, think rats. Or I mean, not rats, bats. This little guy right here. This is like Dirty Jobs, right here on the left, and this is just like a white trash version of Dirty Jobs, where there's no OSHA. So, found in contaminated soil, bird or bat droppings, caves, abandoned buildings, right? Would we see this high risk like in homeless people? They're living in abandoned buildings. There's a bunch of bats and birds just pooping everywhere. It's from the spores in the soil. They get kicked up and then we inhale. Good thing about this one is most people very little to no symptoms. So we actually don't know the true numbers of this because a lot of times people just kind of write it off as an upper respiratory infection, a cough, a cold, and they don't actually get diagnosed with it. Typically, it's when they get more severe that we find it. So again, those nodules, a patient that went to the ER for something else comes back to primary care and say, hey, they told me to follow primary care because they found a nodule on my chest x-ray. You need to work that up. You may do a CT or additional x-rays or consult the ID. That may be how they find this diagnosis or a history of it. Rarely fatal. Typically, if it's going to be fatal, it's going to be in somebody who's immunocompromised, HIV, chemotherapy, something along those lines. But kind of non-discrete symptoms, headache, fever, myalgia, dry cough, thoracic chest pain. What else could that be? Bronchitis, could be fake pneumonia, could be a number of things, right? Frequently misdiagnosed is atypical. So you see this, chest x-ray is not really specific for anything. Where it starts becoming a concern is when it disseminates all over the body, and typically it's immunosuppressed patients. HIV, and as you progress in PA school, you're going to start seeing this more on questions, like how much is CD4 count. So if you see CD4 less than 200, what do we think? AIDS. Yeah, it's progressed to AIDS. So keep that in mind. That's going to be a more common vignette as you progress in school and on your pants. We're going to throw more CD4 counts at you. And since it's disseminating, you're going to start seeing multi-organ system involvement, liver failure, splenomegaly, right? It gets big, start having nondescript GI symptoms, these other things. Diagnosis. Again, a lot of times we just find it incidentally on chest x-rays, but there is an antigen test right here that you can do, and a tissue biopsy. Typically, the only time they're going to do tissue biopsy is if they have that right here, progressive disseminated, or you have a nodule, get CT, and it doesn't come back as conclusive for anything, you can't rule it out, you'll send it to pulmonary or surgery, they'll biopsy to determine what the cause is, and a lot of times they'll find this incidentally. Most infections, no treatment, it's self-limiting, it resolves. But mild cases, start giving some antifungals. Severe cases, these patients are going to be hospitalized, they're going to get IV antifungals. Anybody ever seen this? Right? How do we say that? Actidiomycosis. So we had one of our helicopter pilots get this at NTC. Anybody here been to NTC? Beautiful place. So beautiful. I can't recommend it higher. If it comes up for an assignment after your phase 2, jump on it. Yeah. You will not regret it. No Navy here, right? So 29 Palms is nearby. Hopefully you know that don't pick that assignment, right? I'm telling you how HRC is going to try to sell it to you. I'm telling you how the Army PAs works. They're going to be like, hey man, great location, you're halfway between Vegas and LA. That's exactly what they're going to say to you. And then you look on a map and you're like, man, it's 2 or 3 hours from each location, I can't live anywhere. Barstow is even 45 minutes, and Barstow by no means is a nice place, right? If anybody's ever spent any time there, there's a lot of meth. What's that? Yeah. Desert rats. We diagnosed one of our pilots with this, right? It'll make more sense as we talk, right? So, southwestern U.S., Mexico, South Central America. If you look at the map, it's kind of more close map. It's more of West Texas. San Antonio is kind of like the edge of where you may see it. But if you practice in Southwest United States, you're going to have a higher index of suspicion of this versus somebody who is trained and works on the East Coast or on the Pacific Northwest, you don't see it as often. So again, this talks about why we talk to patients, recent travel, recent deployments, their history, did a family member go there, something along those lines. But again, inhale when soil disruptors lift up by wind. So it makes sense why a pilot would get it, right? So wind gets kicked up and the rotors go, he inhaled it, came back, and then we thought it was an atypical pneumonia. Turned out it was that ID. He's still alive. He had a fine outcome, but just based off that history, it was another PA that had kind of a low index of suspicion thinking about NTC. Immunocompetent patients are typically asymptomatic. They may have those mild symptoms right here, minor flu-like illness, again, is the malaise, slight fever, cough, just kind of feel run down. They chalk it up to having upper respiratory infections and cold virus. Might be a highly opportunistic infection with HIV patients. So what do we think CD4 or the count would be? Yeah, as that count starts dropping, they become more susceptible to infections. So primary, and those mild things, we start seeing more of those musculoskeletal, swelling of knees, ankles, body aches, pain. 50% are going to have normal films, or 50% are going to have these kind of nondescript right here. Either adenopathy, those lymph nodes that are right there in the central, which could be a number of things. And then as we start to see disseminated, we start to see these other lesions. You guys have Commander DeBoer for cardiology? Yeah. So he has a really good story about when they see diagnosed. The patient, well, I won't steal his thunder, but ask him. It's a very interesting story. It's very applicable to military medicine of kind of how we train you to do all this stuff when we talk to you about being primary care in the hospitals. That kind of goes out the door, out the window when we deploy, right? Limited capabilities, and we can't evacuate everybody. If you look at what's happening in Ukraine, helicopters aren't flying, right? So you can't just evac every patient. So you're gonna, future wars, future conflicts, you're gonna have to be more comfortable sending these patients doing telemedicine, talking with those specialists, because you may not be able to just send people out for labs or imaging. But make sure you guys ask Commander Gordon. It's a good story. But with disseminated, right, very rare, but it's fatal if you don't intervene sooner than later, right? So this will start to disseminate across the body, multi-system involvement. You start to see it in the spine, where you start getting these cavitating lesions in bones. It's a very nasty disease once it goes into the full-blown disseminated. Productive cough, they get these wart-like lesions right here. Fungal meningitis, right? That'll kill somebody very quickly. Mediastinal lining or lung abscesses because it's disseminating and it's going all over the body, kind of uncontrolled at that point. Don't worry about this chart, right? I inherited these slides. Look at the top line of that chart. What does it say?
In dogs and cats.
I didn't see it till last night when I was looking at slides. I was like, son of a gun. I was waiting for some students, so I cut you off. So don't worry about that chart. Instructors make mistakes. Sometimes I'll use the right stuff. But know the treatment, right? Almost all of these are going to be very similar treatments, right? It's going to be antifungals. If you see azole, right, that's going to be for your mild cases oral. And severe cases, across the board for all these, if it's severe, they're going to get IV antifungals, right? If it's mild, moderate, typically it's going to be oral. Blastomycosis. So South Central, Midwest, right? So people that are trained or work in these areas may have a higher index of suspicion versus somebody who trains like in California who doesn't see this as much. Again, same mechanism, it's inhalation of the spores. Primary, it's common form, asymptomatic to the very vague kind of symptoms. They may start having some dyspnea, chest pain, but they're going to have these lesions, cavitary lesions. See the here demarcation is walled off up here, right? And when in doubt, always do the positive arrow sign, right? Just look for the arrow on the chest X-ray. But real world, like so, if you get a radiology report back from radiology, I would recommend the only way you're going to get good at X-rays is what? Look at X-rays. Most radiologists are nerds, and they'll like more than happy to talk to you about it. Just say, hey, I can't see this on this X-ray. Can you walk me through it? They're going to do one of two things. They're either going to take the time to talk to you. Most likely they're not because they want to make money. A lot of times what we'll do is put the dummy arrow on it and email it back to you and say, there it is. Good for it. But ask those radiologists or ask people if it has a report and you can't find it, don't just assume it. Don't just accept it. Say, hey, can you show me? So I know for next time. But it's going to have these cavitary lesions. Difficult to diagnose. Again, so unless you have high suspicion for this, you're not going to get it. Disseminated is very rare, but these wart-like lesions. What other stuff can cause wart-like lesions?
Herpes.
Herpes usually doesn't cause wart-like, it just causes those lesions. What else could that be? HPV, right? What other fungal disorders? The one we just talked about, right? They had the wart like right here. So, treatment, again, mild cases, oral antifungal, severe cases, it's gonna be IV. Aspergillus, right, where is this found? What's that? This is found worldwide, this is everywhere, so this isn't really unique to a specific part of the world. It's gonna be everywhere. Through environment, soil, almost all these have the same mechanism, right? It's a spore, you inhale it, goes to your lungs, and then you start having symptoms. So they're usually asymptomatic, significant immunodeficiency. Again, vignettes in your questions, right? What causes immunodeficiency? HIV with a low what?
CD4 count.
What other ones?
Cancer.
Cancer, somebody who's gone like under chemotherapy, somebody who's on long-term steroid use, uncontrolled diabetes, things along those lines. And then we have a higher index of suspicion in asthma patients, and we'll talk more about that. But these are your three primary forms: invasive aspergillus and aspergillus. So I've seen a fungus ball one time at Vance. It's pretty cool. It wasn't cool for the patient, but it was a cool finding in treating that patient. So, patients with asthma, we're thinking developing worsening of symptoms, and it kind of comes and goes. Have a look. Be very high risk. Like, look at these patients. If they have asthma and they're going back and forth, you get a chest X-ray and it has these non-specific kind of pulmonary infiltrates, then you may want to start thinking about that. IgE, right? We talked about that. A lot of people who treat asthma patients just go ahead and order IgE as baseline when they're asymptomatic, and then may kick up if they're symptomatic. Skin testing, send them to allergy to get that evaluated. But it's that confusing on and off symptoms. So, got a patient, known diagnosis of asthma, can't find any other co-infections, and they're complaining about it. Hey, I'm taking my meds as prescribed. You've gone up on their steps, on their GINA or their INH forms that we talked about in asthma, and they're still not improving. It's coming and going. Think this. So, reported 20% of poorly controlled asthmatics and cystic fibrosis patients. So we're going to give oral prednisone to knock down that inflammation, give them some symptom relief for, again, weeks to months. So is that going to affect their immune system? Yeah, make them more susceptible to other things. Bronchodilators as needed to help with that. Typically, if they're known asthma, they already have that PRN, you may just tell them, hey, you may need to take this more frequently. And then antifungal medications indicated in some cases. But if you suspect this, typically these are going to get referred to pulmonary or allergy clinic and let them work them up, or they may advise you on how to work them up. Invasive, very rare. Again, it says immunocompromised patients. Who would be getting stem cell or bone marrow transplants? What kind of patients? Most likely cancer patients. There's some other conditions where they could get that treatment, but most likely those are going to be cancer patients. Again, mild respiratory infection. I feel like every one of these things we keep talking about, it's these mild things. So you have to be quick to pull the gun or to refer these patients because they're going to have a lot of vague kind of generic symptoms that you can see with a lot of stuff. But alveoli, pulmonary blood vessels, spread along the blood to the heart and central nervous system. Brain abscess, very high mortality rate if left untreated. Typically, these patients are going to be admitted. And then now we get to the aspergilloma, the fungus ball. Basically, the positive arrow sign, right? This is a very distinct finding right here. You can see that round mass ball with a pulmonary cavity. Round mass ball with a pulmonary cavity. Say one more time. Rounded mass ball with a cavity. Fungus ball. This is what we're thinking, right? Surgical resection. So the guy at BAMC, when we treated him, ended up getting a lobectomy and that whole lobe removed because he wasn't responding to antifungals. We were trying nebulized antifungals at first, and they were doing bronchoscopies and doing direct injections in there with it. It still wasn't working. So last case was he ended up getting a lobectomy and resolved. And the way it started was, actually that COPD was on chronic steroids because their COPD wasn't improving. And then it turned into this when they got CT a few weeks later. HIV pneumonia. Bob Cole all day, right? In the real world, you're gonna see this over and over again on pants. I've taken the pan ring out 3 times. I didn't fail it, I've just taken it 3 times. I'm old. I've seen it on every time I've taken the pan ring. It's all on my pants. You're gonna see it in phase 2. They're gonna get pimped out by a phase 2 coordinator instructor. When I say pimped out, that just means they're gonna single you out and ask you questions. Nothing more, don't read into what I'm saying. But it's just what they say in medicine, right? You get pimped out. It means either you showed a vulnerability or that attending was having a bad day and they just want to make an example out of you. Or you smiled and they were having a bad day, or you looked disgruntled and they were having a good day. They'll single you out, they're going to ask you this question, right? So, PCP, it's going to be HIV/AIDS with a low CD4 count, right? Fungal infection, it has a very diffuse pattern right here. But if you see pneumonia in an HIV patient or AIDS patient with low CD4 count, think PCP, right? Symptoms, dry cough, asymptomatic, or fever. They have blunted febrile response. Why would they have a blunted febrile response? Yeah, it means their immune system is compromised and they can't generate enough of an immune response to actually create a fever. So, known diagnosis of HIV, pneumonia, I'm thinking PCP. What am I treating with? Bactrim, right? And oral steroids, if O2 saturation drop below 95%. If they're admitted to the hospital, the ID team, infectious disease, may prophylactically go ahead and give steroids, but for testing purposes, O2 saturation drop below 95, we're gonna give O2. But again, HIV, AIDS, pneumonia, think this. All right, any questions?